Hello everyone. Have you ever come across calcified root canals while doing root canal treatment? Then this video is for you. In this video, I am going to explain a simple technique. If you are following that simple technique, you can negotiate most of the root canals without any complications. Let's go into the presentation, and you can see a small graphics over here. Here you can see a root canal in which whatever I have shown in the yellow color, it is the root canal calcifications. Now you can understand that in most situations the root canal calcifications means there will be a wider canal, but the calcifications deposits on the surface or the walls of the root canals, making the canal narrow and irregular. If you are trying to negotiate this type of calcifications, these calcified structures may obstruct the files to go and reach the full working length. So let's see how to negotiate these canals. So we can also see a small example. We can see a radiograph of a grossly destructed molar tooth where we can see the distal canals are quite wide and the mesial canals are quite narrow. You may wonder that you are able to see the canals. In most of the clinical situations, this will be the scenario. The canals will be quite narrow and it is not completely absent, as you may think that in many clinical situations we complicate and we make the canal with some form of procedural errors like canal blockage, like ledgers or incomplete canal negotiations, and we complicate it rather than the canal is so absent. In most clinical situations, the canal will be present, but it will be very narrow. So we shall use a technique in order to negotiate it without any complications. One of the biggest mistake or a blunder that most people who do calcified canal negotiations are using a single file to negotiate from coronal till the apical end. That is not going to work because the canal is quite wide in the coronal part with more calcifications in the coronal part, and getting towards the apical part, the canal becomes narrower and narrower, and the amount of calcifications in the apical part also will become lesser and lesser. So understand, coronally there will be more calcifications but a wider canal, and towards the apical part it is a narrow canal with less calcifications. So keep this in mind, and the technique that I am going to tell is called as 15 10 8 10 technique. What is this? These are just the size of the files we are going to use. Let's go into the technique and how to use it. So let's take up a root canal where you can see that there is quite a lot of calcifications. First thing that you have to do is divide the root canal into three parts, as we always do for cleaning and shaping or for any purpose: the coronal third, the middle third, and the apical third. So once we have done that, the coronal third we have to negotiate with a 15 size K file, and the middle third you have to negotiate with a 10 size K file, and the apical part you have to go for the 8 size file. I prefer to use a 8 size D finder or a C+ file, any of the file of your choice, but not the conventional file. You may wonder that why I am choosing a 15 and a 10 size K files, and also the apical part I am going for a rigid file which is smaller in size. The reason for that is the K files have a tip which is quite active, but the D finder or the C+ files which we are going to negotiate in the apical part has a tip which is partially active. So just recall what I just told just before, that the canals are quite wide with more calcifications in the coronal and the middle part. So in those situations, we need a file which can cut through the calcifications and go. But in the apical part, we need a file which is small, but at the same time, it has to be narrow and it has an ability not to cause any apical transportation, but at the same time it can pass through the calcifications if it is present. So all these mandatory requirements are fulfilled by the sequence of the file that I am mentioning. So the coronal part, the 15 size file. So what we are going to do is, in the coronal part, we take a 15 size file and go to the coronal 1/3. Even if you could push the file beyond that, do not do that. Why? Because the calcification may get loosened and it may travel close towards the apical part and it can cause canal blockage. So we should not do that. So the coronal 1/3, we have to use a 15 size K file, and now we could remove most of the calcifications from the coronal part. And the second stage, we have to use a 10 size file, again a K file, to go to the middle third, and again we are just enlarging the canal with a 10 size K file. What motion that we will see, I will explain with a extracted tooth, where you can see what motion and how to do this canal enlargement. So after doing the middle third enlargement, now you can use a definder or a C+ file, and now you can negotiate the canal to the full length. Now there will be no complications. Just remember that if the 15 or 10 size file, even though you could get and feel that you could negotiate the entire canal with 10 or 15 size file, never do that. Go with a definder or a C+ file, and with the help of an 8 size file, negotiate till the full length. Now the entire canal is negotiated, and now you have created a pathway. But the pathway may not be very complete. Now again you can use a 10 size file to negotiate the canal completely. Then you can go for the orifice enlargement, create a glide path, and you can proceed with your root canal treatment. Now let's see an example. So these are the files that I have just mentioned: a 15 size K file, a 10 size K file, and a 8 size definder, in the sequence of using 21 millimeter 15 size, 21 millimeter 10 size, and 21 millimeter 8 size. You may wonder that if the root canal is quite long, why can't we use a 25 millimeter file? Trust me, the shorter files, that means the 21 millimeter files, are more rigid compared to that of 25 millimeter files. And for canal negotiation, we need a file which is rigid and flexible at the same time. So in order to enhance the rigidity of a smaller file, we have to always go for a file which is of shorter length. So for canal negotiation, we should always use a 21 millimeter file and not a 25 millimeter file. If the canals are more than 21 millimeters, now you negotiate the canals to 21 millimeter, then you can proceed with a 25 millimeter file. So this helps a lot in canal negotiations. So these are the 3 files. So you can take these files, keep it in a sequence, and now what we are going to do is, just this is a model, just we have isolated it. The first step is, after access preparation, as with any procedure that we do in root canal treatment, is irrigation. So before canal negotiations, we cannot do an irrigation. So I have added the concentrated solution of 5% sodium hypochlorite in the pulp chamber. While doing canal negotiations, the pulp chamber should be always filled with sodium hypochlorite and not EDTA. EDTA will cause more of procedural errors and it will not help you for canal negotiation. So never use EDTA at this stage. At this stage, simply use sodium hypochlorite. Once that is done, now you remember that. So the coronal 1/3, we have to negotiate with a 15 size K file. So take a 15 size K file and try to negotiate the coronal 1/3 of all the 4 canals. In this model, there are 4 canals: the mesiobuccal, mesiolingual, distobuccal, and distolingual. You can see that I am using a 15 size file and I will be using a clockwise, counterclockwise rotation to a minimal amount, maybe 30 degrees to 60 degrees, nothing more than that. So if you are using this motion, we will never create a ledge. At the same time, you will never create a blockage, and you will never fracture a file also. So one by one canal followed by the other canal, just enlarge or negotiate the coronal 1/3 only. Do not push. If you are pushing, you are going to block the entire canals. So the mesiobuccal and the mesiolingual I have negotiated to the coronal 1/3, and now the distobuccal and distolingual we shall do just the same. The coronal 1/3 enlargement we can do. Okay, so the use of having the sodium hypochlorite in the pulp chamber is, whenever the file comes out or it goes inside, it will remove the calcifications and it will get dissolved, or the debris will be removed in the sodium hypochlorite. So you need not have to wipe each and every time while doing canal negotiations, and there are no chances that these calcifications or the solid mosses will go and it will block the canals too. Once that is done, so in the second part, so we have enlarged the coronal 1/3. So in the second stage, we have to go till the middle third and we have to use a 10 size file. So now you can see I am using a 10 size K file, again 21 millimeter, and I will push it little more deeper inside. You may wonder that we are not sure of the working length. So at this stage, you can use the tentative working length or the average length of the tooth. For example, a molar, a mandibular molar, will have a length around 19 to 20 millimeters, most of the clinical situations. So following that, 1/3 of the coronal we can divide it by 3 and you can negotiate depending upon that. So in the same way I used a 10 size file, here I am in the same way I used a 15 size file, here I will be using a 10 size file but going deeper up to the middle third of the canal. Again I will be using only the watch winding motion, and if needed, if you find the canals are quite wide enough, then you may use little circumferential filing. Once that is done, now you can see that you have removed up to the middle third, you have removed or made the canal wider. Now you can go for the narrow file 8 size definder. So in this case I am going to use a definder. I am using a definder, and with the help of that I will go to the entire 19 millimeter, the tentative working length, for example 19 millimeter. So or unless I get a definitive stop. So with the help of a definder, it will be quite an easy task. Why? Because we have already enlarged the coronal and the middle third. Now it is the apical part. Now the 8 size file without any coronal interference. What happens is, if you are directly taking a 8 size file and if you are trying to negotiate, the calcifications from the coronal part will move towards the apical part because it's going to be loose and it will block the apical part of the canal. So as we have already removed these calcifications and we are having a pulp chamber filled with sodium hypochlorite, this blockage of the canal is not going to happen. So you can see that all the canals that I have negotiated till the full length, and after doing that again, so now you can see that we have negotiated till the full length. Now what we are supposed to do is take a 10 size file, 10 size K file. You can use a little up and down motion or maybe a pull and push stroke, and now you can negotiate or widen the canal which was already negotiated by the 8 size file, maybe to create a smooth pathway, and then you can take the working length, maybe the tentative working length. If you are using apex locator, at this stage you can measure the working length, or you can take a radiograph, and if there are some modifications needs to be done, you can do it with the help of a definder, that is 8 size definder, or with the help of a 10 size or 8 size file, and you can proceed with working length determination. So then you can proceed with the orifice enlargement, and you can create a glide path, and you can proceed with a root canal treatment, or that is cleaning and shaping. I have already made a video how to create a glide path. If you haven't seen, I will put the link in the description. Just watch that video also. It will be really helpful to create a glide path. If you have created a good glide path, then the procedural errors during cleaning and shaping will be very minimal. So now I just created a smooth pathway with a 10 size file, and after that you can put all the canals with the files, maybe a 10 size file in all the 4 canals that we have negotiated, and then you can go for a working length radiograph. You may ask me at this stage, why not, or why shouldn't we use a 10 size C plus files or D finder and a 15 size or 12 size file? In most situations, as I have mentioned before, they have a partially active tip, and a 10 and 15 size files are too rigid, and we do not need that much rigidity. And the 10 and 15 size file we are using because the tip will be quite very active. So in the coronal region we need an active tip. That's the reason that I am not using D finder size more than 8, and this is the only place where we use D finder. So now we can create a glide path, and then we can do cleaning and shaping. So this technique, I call it as the 15 10 8 10 technique, which if you follow this technique, it is root canal treatment, canal negotiations are going to be easy. At this stage, I want to make sure that if the canals are completely calcified, means 100% calcified, which the situations are unlikely, but if it is the situation, then canal negotiation may be difficult, or in some situations it may be impossible. Trust me that you may see most of the cases in social media of calcified canal negotiations. You will see only those successful cases and not every cases. Hopefully you people understand what I am trying to say. So I have more. I just want to keep the video short. There are many things which can be added along with understanding the canal negotiation, like how the calcification starts, why there will be more of coronal calcifications and less of the apical calcifications, why I mentioned that there will be always a pathway, and we should use a smaller file in the apical part, and what's the type of the calcifications we can see. Then the evaluation, shall we use a radiograph or shall we use a CBCT, how to check in a CBCT whether the canals are calcified, how it will look. Then what are the other instruments other than this files? Are there any other instruments which could be used for canal negotiations, and what are the techniques like the watch winding, like the up and down motions? Are there any other techniques for canal negotiations, and what's the role of EDTA? I never mentioned about the role of EDTA anywhere for canal negotiations. Many people have a misconception that if you use EDTA, canal negotiations are going to be easy. Trust me, if you use EDTA for canal negotiations, your negotiations are going to be very difficult, or you will end up with doing some procedural errors. We shall see about that. Rotary files in canal negotiations, we should not use it. What are the reasons? There are some situations we may be able to use. What types of files can be used? And there is something called as the bounded file and the binding file. So if you are doing a canal negotiation, if the file gets binded, we can proceed with the negotiation, or if the canal gets bounded by the coronal portions, we cannot. We can see all those. So put it in the comments, see whether if I want to make a video on all these topics, I will do that, maybe based on your request. So thank you for watching this presentation till the end. So to summarize it, whenever there is a calcifications, do not panic. Prepare an access that is quite wide enough. After that, Use a 15 size, irrigate well with sodium hypochlorite. Make sure the pulp chamber is filled with sodium hypochlorite. With a 15 size K file, negotiate the coronal 1/3. With a 10 size K file, negotiate the middle third. And with the help of a D finder or a C plus file, negotiate till the full length with a 8 size file. And then with the help of an 10 size file, create a pathway or negotiate completely. And then you may go for a tentative working length determination, apex locator or radiograph, and then you shall proceed with the regular treatment, that is cleaning and shaping. Thank you. Subscribe to my YouTube channel Smart Dentistry. I will make more videos. I am definitely very confident that these videos will be helping in your clinical practice. Thank you. Have a nice day.